This podcast is for educational purposes only. Please consult your doctor before changing any medical care. This information, products, or comments contained within this podcast is not approved by the FDA for the treatment or diagnosis of any disease. Although we attempt to keep the information up to date and current, we cannot guarantee the information is up to date at the time of this recording. Individual results will vary. No one should expect the outcomes or results mentioned or described in this podcast. Health shares do not constitute health insurance and do not provide a guarantee to pay for your medical bills. Please consult your broker, general counsel, and/or doctor before changing your healthcare plan. Envita and Envita Health makes no guarantees for outcomes and results. Hello, I'm Dr. Prato, founder of Envita Medical Centers and CEO, and I'm here with Dr. John Oertle, one of our medical directors and involved in a lot of the Envita planning and care with me on our team. So, John, thanks for joining me. I know in our busy day, we get a chance again to talk about more cases so we can share this with people, our patients and others. So today we're covering a 70-year-old non-small cell lung cancer. And if I understand correctly, it was presented at one of our tumor boards, so we're representing this here. And this patient was so advanced in care that he was referred to hospice and not even offered any care, which is very interesting. So again, another difficult case. We like to pick these more difficult cases because I think they showcase the beauty of precision and how precision oncology is the future, in our opinion, clinical opinion. And with the data and the results that we see, precision is going to continue to expand, making the treatment for cancer better quality, length of life for patients. So, John, let's go ahead. I'm going to let's see if I can share here with everybody the screen. Oh, there we go. So we have this case here, and can you see the case?
Yeah, so Dino, I'm going to jump on in here. You're right. It's a 70-year-old male. This was a non-small cell lung cancer. This is a very common type of lung cancer. But this gentleman, as you can see here too, just to note, he had a 25 pack year history of smoking. And he stopped smoking in 1997. I just want to note, really important when you look at root causes, this was likely his cause, was the smoking. And what's interesting is that he stopped in 1997. Really interesting is that even though you stop, you want to be able to actually pull out and identify any carcinogens, which are the cadmium and the heavy metals that can still remain in cigarette smokers. Never did that. Never evaluated the chemicals that were actually accumulated in that from 1997 until when he came on in to see us. But he was essentially recommended hospice when the docs did a full workup at home. He was recommended hospice by especially this radiation oncologist, said, I'm not going to touch you. I don't want to treat you because you're too far advanced. You have too much disease everywhere in the body. Now, this radiation oncologist also is not providing precision radiation oncology, which he understands that to be able to treat all these lesions, you got to dose up the body so much and you're driving the radiation all across the body that it's just not precise either.
It would be like, in their mind, palliative care at best. And just for people that are listening, as we get into this case, just from clinical experience, we've been doing this for over 2 decades, you will find lung cancers that have no history of smoking, and their cause of cancer will be typically we see infectious disease.
That's right.
Like mycoses, a number, or pre-existing, that'd be a fungal or a pneumococcal, different types of bacterial, potential viral infections, which can act also as carcinogens in the lung, causing a risk to lung cancer. But this radiation oncologist, sounds like, was saying, look, go home, you're older, you're 70, which I think is still very young, by the way. No care, palliative care at best. So didn't proceed with care. And so then this gentleman makes his way over to Envita.
Well, so Dino, we're also seeing a lot more. It's you're so what in the medical system they think you're too old, and so 70 years old is too old for them to be able to really want to be able to treat you. And we see that the best results for the elderly or even somebody that's 70 years old is precision, because it's more targeted for the actual patient and they're more susceptible to side effects. And you want to make sure that they're being treated with the precision that a 70-year-old needs to be able to actually maximize outcomes.
Well, and the Lord is in charge of our life. He's in charge of when we were born and when it's time for us to go home. And in the meantime, we work hard to extend, save patients' lives using precision oncology. So look at this ECOG performance status scale grade 1. Essentially, this just means the patient has an ECOG score of 1, which means they are not in terrible health, right? You could be in worse condition than that.
So walk around, that you're still able to walk around, you're still able to do normal daily activities. But again, it goes to this whole understanding that this gentleman is still able to walk around, still able to ambulate, still able to do his daily life and daily living, and yet he's still being recommended to hospice. And he comes to us saying, I want more. I want to be able to actually do more than just go home to die. I want to continue to live. I want to continue to fight. And so this is who he was coming on out to see us, to say I still have a good quality of life, even though the cancer is everywhere in my body, and we'll go through the imaging as far as how bad and the significant the disease was. He was still energetic and still had the ability to be able to live.
Let's take a look here. We have his cancer markers: CA 2729, 840, CA 153, 447, and CEA 161. Now, for people listening, these are tumor markers typically tested when you're looking at a patient's cancer, at least one of the diagnostic factors. For Envita, it's a lagging indicator. We have lots of indicators we look at here, but these are high numbers of the markers of this particular cancer, which shows it's present, and it's something that you want to track while you're treating the patient to see if they're responding to care.
Yeah,
so John, go ahead.
A couple of things with this is that these don't oftentimes come up with actually lung cancer. What we do at Envita is we run these biomarkers because this is a good example of, that these cancer antigens, you'll actually see oncologists that will only run CA 2729 or CA 153 with lung cancer patients. Okay.
That's correct.
We can see it with other cancers. This is non-small cell lung cancer. CEA is commonly run with ovarian cancer or with colorectal cancer. We're seeing this elevation in non-small cell lung cancer. So for us, I like more data instead of less. Now, this is a baseline when it comes to just regular tumor markers that most oncologists and NCCN guidelines practitioners will run on individuals to be able to give a sense. We run a whole lot more biomarkers on the patient, but specifically we run these because they can be elevated, and it's a good way to be able to track and monitor progress of disease. But as you're saying, it is a lagging indicator. So what that means is that CEA is a good example. CEA is elevated, but you can sometimes see when it comes to treatment, CEA elevate because you have die-off. And then it starts to be able to drop. So you want to be able to cut through the noise to be able to see accurately when it comes to what is actually going on with a patient, and are they responding or are they actually worsening to care? And it's
let's take a look at a few of the genomic markers. These are a little bit more common, but we can take a look at some of these markers here. So go ahead, and I'll let you present as the team was at the tumor board. So here you have.
So this is what we call, again, this is our cell-free DNA. What this is that we literally have the ability to be able to take a blood sample, and this is cancer DNA that's coming from the cancer cell that is now floating around freely within the bloodstream. So I give this example. Many times people know now that you can, if a mom is pregnant and you can run the mom's blood, but you're running the baby's DNA. Okay, this technology exists now for anybody that's been to an OB. They get in the last 5 years, they know this technology is now offered in an OB's office. This is the same way we're running the patient's blood, but we're actually looking for the cancer DNA in the.
So the way this is done, so I can help people explain, is that blood is taken from your arm like a normal blood draw, and then the cancer cells are separated, right? They go through a process where they're separated, and so now we're looking at cancer cells, so we can look at circulating tumor cells, and CT-free DNA that is circulating in the bloodstream. Isolate that, which is more of a leading indicator, right? Because these changes will happen before you even see changes in the tumor markers we were looking at.
Okay, so to look at the slide here, this also, again, you'll see that they're broken up into mutational burden and then mutant allele fractionation. This mutant allele fractionation, it's all those percentages there. This actually leads to really, again, favorable prognosis or poor prognosis. The higher the amount of percentage of allele fractionation. This is how many mutants of the chromosomes of the actual DNA are floating around in that bloodstream. The higher that mutational burden is, the worse prognosis. Okay,
That's right. It's harder to treat because that means the cancer is moving and changing these specifically at these genetic markers, right? At these specific actionable, sometimes non-actionable target markers, you start seeing mutations that are picking up, which is also a quasi sign, but partial sign to mutate to metastases, right? As we got more mutation, more CT-free DNA, more. This could be a sign of growth of the cancer or spreading or making it more difficult to treat.
now, even with that, even though it's a sign of worse prognosis, you also see that the higher mutational burden of a cell-free DNA that's actually floating around in the patient's bloodstream will show that there's a higher likelihood of a response to immunotherapy. So this is why it's so interesting. You have these really advanced cancers, and I don't disagree with the oncologist or the radiation oncologist who's saying you are very advanced. You have a high disease burden right now, but this is actually one of the ways that immunotherapy can shine, because immune system is all trying to be able to figure out, I want to remove a foreign invader, and cancer is your own cells, and just think that your body doesn't want to attack itself. But as there's more mutational burdens that are there for the actual cancer, now the immune system can recognize it and kill it. So it's actually quite interesting that the more mutational burden increases or worsens your prognosis, but not for immunotherapy. It actually improves your response to immunotherapy.
So let me add to this a little bit, which I think is very important. One, Envita has 23 years of doing this work. We have advanced bioinformatics we use, right? These different markers and data, a whole bunch of different data points that give us precision for each patient. What Dr. Oertle sharing here, or John, what you're sharing is that when we see higher mutational burdens, that's at least one marker, there's many others, that is telling us that this is a immunotherapy potentially benefit patient. Now, we already know that non-small cell lung tends to be a hot cancer, hot meaning more responding to immunotherapy in general. So that's why when we look at these things, it's very important that we're reviewing them and saying all of these things are giving us data points to help building precision care. Now, there's many more data points than that, but these are nice that we can share some of those. Let me move on. So do you want to go? I mean, we have EGFR here.
When you see this EGFR mutation, you'll see 96%. That is a huge, only 4 more percent and you're at 100% of the amount of mutations that you can have. That is a very high level. That doesn't occur very often. This means that this is a very advanced, very mutationally aggressive cancer. And again, 96% is a death sentence to a lot of people that would go to even have this level of testing.
This is a growth factor, right? This is a growth factor to the cancer, so it becomes critical to treat it to slow down or stop its growth. So I'm going to move on. I mean, we were looking here at some of these targets. When we run these tests, just so people know, we have a laundry list of different data we're looking at. Here we just picked out a couple of key points. The EGFR is the highlight of one of the pieces to look at here. So, okay, I'm going to let you go through this PET scan where it's so clear to see all of the metastatic cancer in this patient, especially from the chest up in the mediastinal area here that we're looking at. It looks like very, very active disease where the PET scan has picked up this metastatic spread.
Yeah, so a PET scan, essentially what a PET scan does is that it takes up it brings a radioisotope, usually sugar, radioactive glucose. It's injected into the body, and then the cancer, because a cancer cell loves glucose, attracts more of that radioactive glucose. So what you're seeing in this image is that all those places that are dark are areas where the tumors have picked up that radioactive isotope of glucose. And it's now, we're taking an image on it, and those tumors are lighting up like a Christmas tree. Those lights, you can see them on imaging, and you know exactly where they're at. As you can see, these black dots that are littered all over the body are tumors within this actual patient. All those black dots are where tumors are located outside of that big black blob right at the bottom of the image. That's the bladder. So
Bladder.
that's not cancerous, but those other black blobs are all highly concerning of metastatic lesions in cancer that's
But you
rapidly
can
growing.
see the patient, as you can see here, would have their arms up, right? And you can see from the area of the neck going down through the chest, all that metastatic disease. Again, lower abdominal, in the abdominal area there, you have also metastatic disease. And then the other is just a collection of the dyes that's eliminating the body. So this is
Correct.
a widespread metastatic. This is why that radiation oncologist said, go home. We can't, this is widespread. It's a 70-year-old patient. And this patient, praise God, wanted to live, so continued on and reached out. But this is important. Let's move on to the next slide here. So go ahead. I'll let you continue and
And this is a
just go over these
description
findings.
of all those lesions everywhere littered throughout the body. And it was in it's in the lungs. It's in what you'll see here it's in the right middle lobe. It's in the lymph nodes in the center of the chest. It's in the abdominal wall. It's
Yeah, it's
all
everywhere.
it's everywhere. And so this just gives a radiological the radiological language that would be in a report. Do you want to go on?
Yep.
All right. So what did we actually recommend? This is great. So we recommended initially when he came on in, and this was at the beginning of September, we recommended our algorithm that allowed for GTF chemotherapy. And this is our genetically targeted fractionated chemotherapy. This means that the genetic targets for the chemotherapy are precise to the patient. And then we do it in a lower dose to be able to make sure that it doesn't kill the body at the same time that it's treating the cancer, which
And
is
it's going to
really
use,
important because immunotherapy, you don't want to give high dose chemos that are going to kill off the very thing that your immune system, it would kill off the immune system, the very thing that is trying to be able to actually respond to this tumor.
yeah, and it's important to recognize that in that GTFC, genetically targeted fractionated chemotherapy, we're going to pick actionable targets for that EGFR and others. So there's going to be a very good match. We're not, so oftentimes, and I would say to any oncologists out there, if you are going to start using precision oncology, lung cancer is a great place to start. Most of the high level genetic tests that are done across the country are there. Lung cancer has some actionable targets that can really make a difference in the length, quality of life, and response to the patient. In this case, you have the EGFR, you have some other targets, and that plays a huge role for this patient in their care. It plays a big role in part of the care process.
Well, the other really interesting thing too is that EGFR is a growth factor, as you've already said. It makes it so that it's a genetic marker that the cancer uses in a cell to be able to help rapidly speed up and grow. What you actually find is that individuals that have a high EGFR do not respond as favorable to immunotherapy because the immune system has a hard time catching up with tumors that are rapidly growing to the extent that you're not silencing them down. This is where it's this Envita algorithm that you have to understand the combination of targets instead of just thinking, well, we can just do immunotherapy or just throw a PD-1 inhibitor on board or just throw a genetic precision target. There's a combination and a beauty of
Yeah,
being able to actually know what's best for the specific patient.
what you're going to want, and again, this is more of a technical term, you want an EGFR knockdown while you're getting an immunotherapy up stimulation. And it's a specific combo that's very, very, very important. And if you look in the next item, you have the immunotherapy PD-1 inhibitors, where I believe most patients who've heard of anything to do with immunotherapy have heard of PD-1 inhibitors. In fact, they were approved for lung cancer, one of the first cancers they were approved for. And PD-1 inhibitors help the natural killer cell to be able to hit the final target so it's not blocked to kill the cancer. But what's very interesting is PD-1 inhibitors are becoming more, we've been using them on and off label for years to help, not as the main immunotherapy. See, in most oncology facilities, this would be like the immunotherapy. Oh, you're using a PD-1 and Opdivo, Keytruda, whatever the drug might be. At Envita, it is supportive immune because we have actually more targeted immunotherapies than PD-1s, which is incredible because we have a whole approach to immunotherapy that's just as precisioned as we were just talking about there with the genetically targeted chemotherapy.
Yeah, I like to tell patients, Dino, that just using a PD-1, it's almost like taking the cloaking mechanism on a cancer cell and removing the cloaking mechanism. The problem, though, is that even with the best cloaking mechanism that you're able to remove, that if you don't have a good NK cell and if you don't have good T cells in the immune system that aren't actually targeted and honed on in, and that ability to be able to actually hone it on in, it doesn't do anything.
So let's talk about that for a minute, because you'll hear us if you listen to our presentations or talk in the past. What we're talking about here is the ability for the immune system to recognize those specific antigens on the cancer data that's specific to that tumor. Once the immune system grabs that antigen, passes it to the dendritic cell, off to the natural killer cell, the cell now knows how to seek and destroy other micrometastatic cells. So that image we saw back there, if I might dare just go back, what people don't realize, when you see the widespread cancer like this, there's many micrometastatic and dormant cells still seeding through the body, which oftentimes chemotherapy will not touch. But the immune system has the ability, when targeted, which is if you look and go to any of the studies or any of the conferences worldwide, immunotherapy is and will continue to be the future of oncology. And as we get better targeted immunotherapy, we're going to see better remissions, quality, length of life. But it's because not just a stronger immune system, but one that is properly targeted to that specific patient's cancer, which there's a whole process we use to do that, because the immune system just being strong needs to be targeted. Otherwise, the cancer cells have wonderful mechanisms to evade the body's immune system. That's why these cancer cells and tumors spread in the first place. So we have immunotherapy, PD-1, going down here, adjuvant treatments. Now, I'll let you jump in. I know I'll give you some time here, John, to talk about the importance of adjuvant in our algorithms and part of the work that we do.
Yeah, this is where the natural integrative treatments come into play, that they're advanced phytotherapeutics that are targeted specifically to be able to help improve the actual sensitivity of chemotherapies. They help improve the outcomes for immunotherapies. They also can be supportive, not in this case because we didn't use radiation, but these therapies can also help to be able to radiosensitize, meaning that the radiation can become more effective when utilized and paired with these other natural advanced therapeutics.
So let me talk about this for a minute so people understand the importance of precision integrative oncology, which is what Envita is well known for. When you add the proper adjuvants, which we also look for genetic targets for, right? Because we look for genetic targets, we look for how they operate in concert with the other part of the treatment, which is part of the Envita's algorithm. We have our proprietary that's been really through 2 decades of clinical practice developed. We find that combinations can make a big difference. And what adjuvants also provide is a fast way for people to heal. Because when we treat patients with chemotherapy or immunotherapy, you still need to strengthen the body's immune system and their body's ability to fight and to recover. So that's why it's not unlikely that we see patients not only get better with the disease, but they have more energy, better quality of life. Some patients able to go hiking right in the middle of their treatment because we're looking at the half-life, we know when that drug is acting, and then we're cleaning it out and we're helping the body heal. And that's a mistake, I think, in the conventional model of oncology, is assuming that, your body naturally does that. Let me tell you, if you support your body with the proper adjuvants, nutrients, you're going to heal faster. You're going to recover faster. Your immune system's going to do better. That's critically important, at least in my several decades, especially in late-stage cancers where patients need more support and energy because they may be already more run down than just, an earlier stage type patient.
That's right. So we also, if you see here too, we also gave oral smart drugs. So we gave chemotherapies that were in an IV through our GTFC. We also gave oral drugs that were specifically based upon the patient's specific targets as well. One of those was an oral medication targeting that EGFR. And then we also gave other supportive medications. So there's other off-label use medications that we give orally that are going to do different mechanisms to shut down those mechanisms that the cancer uses to be able to advance and to be able to get away from the immune system.
All right, so here we're looking at a graph of the CA15-3. Okay, it's at 447.
This is great, Dino, because this is the proof is in the pudding. So what you're actually seeing is that for everybody watching this film and this graph, the highest number right over there, the 447, that's when the patient had originally arrived to Envita, which actually, if you see there, that's based upon the beginning of September. If you look at that target,
fairly recent patient. Good.
and then what you're seeing is that a tumor marker, right? Again, this is a tumor marker that's traveling on the actual cancer. This patient responded. And so what you see is that you actually didn't have a jump up. You actually just saw it reduce down. So you're seeing that it was a little bit lower in the next month, a little bit lower, and then you're seeing it completely resolving in a normal range into December 5th of when it was ran. This is
so from the right, as we're looking at the screen, from the right to the left.
To
right?
the left.
Yeah, you're seeing the numbers.
As you're going left, you're going more current in time.
Yeah. And so what's happening is from the right, it's high, and to the left, it's low. And here you can see the patients responding to treatment.
That's
the
right.
Numbers dropping, just so people understand this is read from left to right so they can see it. I'm sorry, from right to left, where it's higher on the right side and drops on the left. And you can see the marker decreasing, which is a great sign here. And the biggest drop right at the beginning of treatment.
Right at the beginning of treatment.
Those targets. So this is confirmatory to us when we see these targets dropping so quickly. We're spot on. And let me say that it is not uncommon on many cancer types, but particularly lung, for us to see really, really good results with good targeting like this.
And we don't just use one target. We use a multitude of targets. This is a really good example. CEA. I think you can remember hearing me say that CEA can elevate when there's die-off, and it can elevate when there's inflammation. And so this is where it's really good to be able to not just use one target, but use a multitude of targets. And as you see, this gentleman responded initially, just like the other tumor marker, the CEA, as you can see from right to left, it dropped initially. Now what we see is that it started to be able to increase again. What's that telling me? It's telling me that there's die-off because the other tumor markers are dropping. There's other information that's telling me that the treatment is going well. And then what you see, don't worry. A big part of this is in the wise oncologist knows that when treatment is working, you may start to see an elevation in tumor markers with an eventual drop. This is what, if you just stopped there, you would say, I'm a little concerned about this if you didn't have those other markers to be able to track and monitor. But you see it eventually completely cleared.
Here we're looking at the blood tumor mutational burden, microsatellite status, and we're also, again, looking at those markers. What's interesting, I want to point out the EGFR, which was the one that was very high and most concerned about. You can see here the difference of these. Go ahead, I'll let you take over, John.
But it's not just EGFR, but all of the DNA mutational fractions are gone. There's no detectable DNA in this patient's bloodstream once we got to in December. You'll see that there's still a little remaining in that when we ran it in November, but that EGFR went from 96% down to 0.13%. Everything else was not detected, and then it completely removed when we actually got into December.
And I just want to say that less than 20% of all oncology uses any precision. They don't run these tests. And maybe 10 or 15% get any of it in their treatment plan. And so when you look at this, and you wouldn't be surprised if you go and look at your labs, these were never run because they're not doing precision. But one of the nice things here is this mutational non-detected, where you see to the far right it's non-detected. Everything has been shut down. Why we're presenting on this case is because it's a classic example of how precision can be life-saving and dramatic in the treatment of a patient. So let me move on here. So let's go through this.
This is in another graphically represented way. This is again. It is the actual the
genetic information,
and you're seeing it's gone. It literally when we get out into that The left is all the mutations that we're seeing.
Dropping.
That big one, that big dark blue one, that's going to be primarily the most. It's going to be the EGFR. But what we're seeing is that it completely clears. There's no
So this
more
is a graph.
mutations in this patient as far as DNA of the cancer.
This is a graph from left to right that is looking at the genetic mutations that have completely shut down in this patient.
They're
So
gone.
when you look at genetic mutation, it is in part a prognostic factor. It can get worse when disease is progressing. It can become very difficult to treat. Like you said, it also can give keynotes that we need to move to other therapies like immunotherapy. But in this case, you can see it drop so beautifully from left to right that it was shut down. That's exceptional work by our team, exceptional bioinformatic algorithms that we have in Envita. And this is a beautiful textbook response to why precision oncology should not be avoided, but used, I believe, in every single cancer type, but particularly in lung. And you can see it here. Okay, let's take a look here at this imaging. John, I'll let you go ahead.
Yeah, this is another PET scan. It's the same. It's the same image, the same technology of using the glucose that absorbs to be able to light up any knowable cancer like a Christmas tree. And what you see, there are no further lymph nodes actually seen on this actual PET scan in the end of November. You're seeing.
So how long was he under treatment before?
Is all the cancer, all those tumors, all those black dots, and the right, it's almost completely clear. Now there is still this little that you see that there still is maybe some gray patches there, but then this literally is almost completely clear. I also want to share that when we ran it again just recently, now it's completely gone.
So let me explain this to people who maybe not be looking at this image. You have tumors all through the chest that's like black everywhere. We're not talking about tiny dots everywhere. This is in October 3rd. By November 28th, which is like basically a month and a half, okay, the patient has no tumors left in their chest. It's completely clear. All you're seeing on the PET scan is the kidneys, which are clearing the contrast. The rest of it is totally clear. And
That's
now, most recent films, right, that we just did, it's totally 100% clear. This is beautiful, praise God. We love these results, and we love seeing our patients have this. So here's a 70-year-old man who's been sent home to die, or by a radiation oncologist, we're not going to treat you because it's too far progressed, and now is in literally full remission. I mean, that is
you know
the
what that
power.
means? You're sitting in your doctor's office getting diagnosed with cancer, and your doctor is saying, I'm sorry, there's nothing more I can do. You need to go home to hospice to be able to just have them give you pain medication and where you're going to go home to die. And when I see this, I think if he didn't know that there was a better option and he listened to his doctor at home, he would have just gone home and died. And he would have, because this is a very aggressive, a very intense cancer that was littered all throughout the body. And with the ability of utilizing precision, now he gets his complete cancer is in full remission. There is no evidence of disease. And when I mean that, there's no images that show any cancer presence. There is no tumor cell DNA, any DNA floating around in your bloodstream, a liquid biopsy that is showing any presence of cancer. And these tumor markers are completely normal. And this is where this was achievable in 2 months.
Amazing.
2 months.
Praise God.
And for this gentleman now has his life back. And
let me add that
really grateful for it.
Let me add that we didn't even have to use very much of our technology for this. This was still using very what we call elementary Envita algorithms. We have even many more advanced algorithms that go into more targeted immunotherapy, more planning in that precision. And here, this just worked so beautifully. The patient responded so well. And here you're talking about the impression where these were clear. This is just the radiology.
And you'll see this is what I was sharing. There was that one little lymph node that was just having a slight uptake, but then that completely resolved the very next time that we actually ran the PET scan as well.
So here's what's powerful about what we're talking about. What we're talking about is that precision is absolutely critical in oncology. It's, in my opinion, it's not an option. Well, let me explain to you why. when you don't have this next level testing and you're just stuck with the type and stage of the cancer or the age of the patient or whatever the doctor's putting into their factors, without running these more detailed components, you really can't put together a good treatment plan. You really can't tell this is the exact markers we're going after, and this is how we're going to track and monitor you. And you would think this is being done everywhere. It's not. Even the most prestigious institutions are failing to do precision oncology. They only do it when everything else fails. It's not in the first part of algorithm. When Envita does precision, it does it at every single level. That means when we're working with a patient right from the beginning, we are looking at all of these parameters for precision right from the beginning of the care.
What's beautiful to note in this case as well, 3 months of care were prescribed. He received 2 months of care because of his response. And so he got to go home early, and this was even exceeding the Envita doctor's expectations as far as how he responded. And so when that occurs again, he goes home and he got to spend Christmas back home.
Yeah, I mean, that's huge. I wanted to take a look. And so one of the things that happens is that you just never really understand what you're missing unless you're doing the full care, right? There's no way to know exactly what your care could be or the technology you could be accessing if you don't use, meaning you don't know what you don't know. So oftentimes people are told, oh, there's no treatment here that's very good, or you're not responding, or they began care, the care stopped working, they're progressing, now let's bring in precision or a clinical trial. But if we use more precision, the data is clear. Less than 20% of patients get precision testing. It's like 17. I think we have it somewhere on our site. But less than 10% actually get it in treatment. 10%. And when they do, it's a watered down version compared to the detailed precision algorithms we use, because we know the future of cancer treatment or giving our patients the best chance to live, quality of life, respond to care. It's precision on every level, not just the chemo, the precision on the immunotherapy, in the way we deliver the medicine, the precision on the integrative agents to support the body or get to the cause. In this case, maybe the cadmium or the carcinogen from smoking. But the point is, precision is the key to oncology. And when you look at this, we were able to do this at 50% the cost of conventional care, 50%, and with 10 times more precision. And that's what we believe every patient deserves. We've been working hard and fighting so that our patients have access to this type of care. That's why we've worked with others to build solutions in their insurance to be able, through their employer groups and others, get covered, because this is better precision care. This is better detailed care than sending somebody home and not giving them the option or not providing quality care. And oftentimes in lung cancer, we'll see sometimes patients being managed maybe with that PD-1 inhibitor, and then it stops to work. Then they come into Envita because they need a next level immunotherapy or a next level targeting, and it should be covered. And so we're working hard to do that for our patients and to help them. And the key going forward here is helping these patients understand that precision oncology is an enormous advantage. They should have the testing, they should have the right targeting, and they need the right deployment of care. That gives the patient the best chance of living and the best chance of responding to care. Now, we can't guarantee all of the patients have this response, but these are wonderful cases that really put on display the beauty of precision oncology, something that, all of us shouldn't be afraid of cancer. Cancer should be a disease that's well treated with minimal targeted techniques, and we should be able to continue to live the life that the Lord has for us. It shouldn't be something that steals our life. And we're working every day with our team. Great work, John, by our medical team. Great work by all of our team. As I'm very proud. We have a great diverse group of physicians, all from every part from interventional radiology, oncology, surgery, oncology, and integrative doctors, naturopaths, the whole team working together, pharmacists, chemists, researchers. I'm really proud of the work you did here, and what a blessing to see this patient respond the way they did. John, do you have anything else you want to add before I wrap up our conversation on this case?
Yeah, precision oncology is not easy work. And it takes a lot of effort, a lot by our team to be able to actually deliver the actual precision and the from the supply chains to the medications to be able to actually allow for the delivery of the care. But this is why we do it. because patients' lives matter. There's a reason why we're not seeing it done across the country, even though the results speak for themselves. It takes a team, as we know, from everybody that's here at Envita, but we do it because it's worth it, because the outcomes
Well,
speak for themselves.
here's the truth. I mean, that patient now goes home to their family, praise God, and they get to share this miracle that happened in their life. This is the goal for that is exciting in my heart after all these years, 2 decades of this work. Every time we see beautiful results with our patients, it's just you see the power of this years of work, innovation, the grace of God working, and people should not be afraid. I want to add this: be not afraid, but instead get the right targets and knowledge. Pray, ask for direction. You'll be given direction and what you need to do, and give your body and give yourself the best chance of healing. But to me, what I've noticed over the years, and I say this with great respect, precision oncology should become the standard, not the other way around. People deserve to have the best first and not last. And we're fighting to make that happen for more people. So I want to thank you guys for joining us. May the Lord bless you on your journey to healing. If you need anything, we're here, and our team is here to support you. God bless you. Thank you for joining us tonight. Hopefully you enjoyed us. I know we often enjoy talking and sharing these stories. John and I can go on forever because this is our passion, our work. But thank you for joining us, and God bless you.